The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of the Genuine Article. And today I'm speaking with Dr. Eugenio Stabile. And Dr. Stabile is an interventional cardiologist at the Clinica Montevergine here in Italy. And he's published a very interesting paper in JACC dealing with carotid artery stenting. And carotid artery stenting is one of those procedures that's still being evaluated as to where it fits in. Tell us about your study.
Okay, so what we did, we reported our experience on 1,300 patients that were treated with carotid stenting using a system of neurologic protection that is based on the occlusion of both external and internal carotid artery. During the occlusion time, you can work on your carotid without having the risk of a distal embolization. And so what we found out, and out of 1,300 patients, the event incidence at 30 days of death and any stroke was only 1.8%. That is, only 19 patients experienced an event out of these 1,300 procedures.
Well, that's really impressive, but it sounds a little bit scary to me, occluding both the external and internal carotid artery. How often do you have acute neurologic symptoms?
So normally we experience neurologic symptoms roughly in 1/3 of these patients, but these were symptoms that were definitely transient. So symptoms were minor and they appeared most of the time at the end of the procedure, and only 4 times out of 1,300 patients we had to deflate the balloons because patients experienced an immediate neurologic intolerance. But at the end of the day, all these patients did not have a major event after the procedure. So even the patients that have intolerance at the end of the procedure and the patients that have intolerance immediately at the start of the procedure, they did not have an increased event rate at the end of the day.
Well, I'm very impressed that you have a huge number of patients, and they were consecutive patients, so we have the total experience. But tell us a little bit more about the patients. Did they range in age, and were they high surgical risk patients or even acceptable surgical patients?
So what we did, we treat really the all-comers. So all the patients that had a clear indication according to the guidelines for carotid revascularization were treated consecutively in our institution. And we had 50% of these patients had a high surgical risk as defined in JACC by the consensus of different American societies. And roughly 10% of these patients were octogenarians. And what we found out, that despite the patients with high surgical risk and the octogenarians have an higher incidence of the event, this was not true in the data that we reported. Because at the end of the day, the fact that it could increase the risk of having an event is not the risk, the status of the surgical risk or the age of the patient, but is only the level of the operator, the experience level of the operators.
Okay, so clearly we'd like to identify those patients most at risk of a complication, and being in the hands of an inexperienced operator. But how many cases does one have to do before one's experienced?
The set of the levels of experience that we set in our paper were 3. So the first level is the first 50 cases that we did, then the cases from number 50 to 250, and then the remaining 1,000. So in the first 50 patients we had a 4% risk of event, and then the 4%. Then the event rate dropped from 4% to 1.2, 1.3%. So roughly after the first 50 procedure, you can be considered an experienced operator with this system, and then you can clearly give your patient a safe procedure.
So now the team, it's just cardiologists, or there are some radiologists, neuroradiologists?
In our cath lab, we are all cardiologists. The way we prefer to work is having 2 physicians at the table, because at the time in which you occlude the balloons. You need to have everything ready on your table. The wire must be there, the balloons, the stent, the balloon that you intend to use for post-dilation. In this way, you can have the occlusion time, a short occlusion time. You can have even an occlusion time of only 4 or 3 minutes and a half. The way we started is to work with 2 physicians and an anesthetist. Sometimes we work with 3 physicians when we believe that the patient is more friable, and so we prefer to be faster. But 2 physicians will be enough.
Yeah, so tell me now, with this experience, huge experience, over 1,000 patients, 50% were good surgical candidates. What now is the practice in your clinic? Are you doing primarily intervention for symptomatic carotid stenoses, or are you using surgery in what patients?
The way we decide the strategy of revascularization for this patient is based on anatomical condition and is based on the patient willing. So we know that with our experience we can treat almost all kinds of carotid stenosis. But if the patient, but we believe that carotid stenting has not the amount of data that are proving safety and efficacy as carotid endarterectomy. So we described exactly to the patient what is the status of the thing. We say that carotid stenting, we believe, is not inferior to carotid endarterectomy, but then at the end, the final decision is up to the patient.
Okay, fascinating data and fascinating experience. Carotid artery stenting clearly is becoming a procedure with which we have more experience, and with experience like this will likely continue to have an increasing role in clinical practice. For the Genuine article, I'm Tony DeMaria.
The Genuine article. Discussion and commentary based on articles from JACC.